everybody. Welcome to this week's episode of Tales from the Doghouse, Separation Anxiety Explained. Just like it says, we talk about all things separation anxiety. We are so glad that you are here with us this week. I am Stacey Bell from Focused Fun in the US.
And you're also listening to me, Sarah McLaren from Separation Anxiety Solutions in the UK.
And I'm Ness Jones. I am in Australia from Separation Anxiety in Dogs Decoded. And today we also have with us a very, very, very special guest. His name is Dr. Pachel. Dr. P, should I call you Dr. P or Dr. Pachel?
Either way works just fine. It's sort of, I'm laughing a little bit to myself now. In my practice here in Portland, there are now 3 Dr. P's in the practice. So I am. It was for a while. It was Dr. P and Dr. P2, and then we became a P3, and so now I'm the OGP. So
nice.
Right. So you can call me whatever you want. I don't really care.
You're 3 P's in a pod now, then.
Yeah,
absolutely.
Nice.
Yes, we are.
Nice one, Sarah. Dr. Chris Pachel, I should say. So maybe you could introduce yourself and just say, tell us about what you do, how you got there, what drew you to being a vet behaviorist, etc.
Absolutely. Well, first of all, thanks for having me on. It's a joy to dive into this particular conversation and, really pick your brains as much as you'll be picking mine and just sort of engaging the conversation and seeing where it takes us. So yes, as Ness said, I'm Dr. Chris Pachel. I am a board certified veterinary behaviorist through the American College of Veterinary Behaviorists. I own the animal behavior clinic here in Portland, Oregon, which I've been in Portland now for about 12 years after running a house call based behavior practice in the Minneapolis-St. Paul area, more central US for 6 or 7 years or so, if I do the math. So I've been a veterinarian since 2002 and working in the behavior space pretty exclusively since 2004. And my practice is not specifically limited to separation anxiety, but as you can imagine, it's a huge part of what we do, whether it's the direct patients that are coming in for consultations or whether we're working with veterinarians truthfully around the world to try to tease out some of the medication supports, or in some of the cases trying to figure out with some of the more difficult cases, are there potentially some medical underlying issues that we may not have either identified yet or we may not have fully treated yet, in such a way that allows them to move forward with their treatment plan. So I have a lot of contact with this particular topic, and I'm looking forward to seeing where this conversation goes.
So would you say currently, because of the COVID lockdown, you're seeing more cases of separation anxiety, which is our experience?
Yes and no. And I say yes and no because truthfully, I've been really impressed over the last 3 to 5 years, especially with the role that the general practitioners have been taking here in the US with regard to really getting a bit more comfortable with some of the standard medical therapies. So I don't know that I'm seeing as much of the uptick as the general practitioners are. They are absolutely seeing a huge, huge surge in that right now. I will say that the patients who are coming through the practice are more difficult to treat. And we can, potentially get into some of those issues in a little bit more of a deeper dive. But I will say, whereas historically we might have some of the more straightforward, well, we can get into that too, but some of the more straightforward cases that just need a little bit of help and a little bit of education, and boom, they're off and running. The number of cases where we're spending a significant effort, both in the medication support as well as from the behavior modification side, that's what really feels a bit different to me right now.
So what made you go from, or what, drew you to behavior as opposed to just being a general practitioner?
In truth, I just realized here probably 4 or 5 years ago, whereas a lot of my colleagues and a lot of trainers and behavior consultants sort of got pulled into the behavior field out of necessity with, an animal, whether it was in their own home or a particular patient on the veterinary side. I actually just realized within the last couple of years that for me, I actually think it was the clients. that pulled me in, the sort of the need and the, to some degree, the desperation that I heard within my clients, where they were coming in with behavior questions. And this would again back in 2002, 2003. And while there were resources available, there weren't a lot. And while there were, quite a few really good trainers, there weren't enough. And so, as the clients were coming in to work with me, I found myself really kind of being taken by the emotional upheaval in their worlds, in their lives, by trying to navigate some of these behavior issues. And so as part of my job, I started digging in and doing some additional continuing education. And well, one thing led to another, and then it was a week-long intensive. And I remember having this realization while I was there, and really just starting to get captivated by the way that the brain works and how that manifests as behavior, specifically in companion animals, because that's really my focus. And I remember coming back from that week-long intensive, and I had called my partner at the time, and I said, hey, not quite sure what to make of this, but I think this might be the beginning of the end of my general practice career. I don't know where I'm going yet. I don't know exactly, so don't panic, but I don't know. I've got a feeling this is a starting of something pretty big, and it has been. I went back into residency then in 2004, and really have been working within the discipline ever since. And truthfully, no regrets. Have never looked back. It's been amazing.
Oh, that's fantastic. How many dogs or patients do you reckon you've seen over the years then, since then?
Gosh, yeah. I mean, I think in the early days when I was really doing, clinical cases, morning, noon, and night, I would see between 300 and 500 cases a year. And so in those early days, it was a lot. Yeah, I see a lot less now, but I mean, it's in the multiples of thousands, potentially in the tens of thousands, probably not tens of thousands, but high thousands at this point. And it really is fascinating that for almost any of the cases that I've seen more than a small handful of times, you could say their name and I would tell you their story right on the call here without grabbing for my files. There's just something about those connections with family, and especially those cases that I saw as house calls back in the day, that you became a part of the community that was rallying around this particular animal. And I know that that's a huge part of separation anxiety treatment as well. But it was, yeah, just that feeling of being a part of an effort versus me taking on the weight of treatment or putting all of that responsibility back on the owner. It really has been the feeling of collaboration to achieve some really, really amazing things.
That's incredible. And what percentage of your patients would you say are related to separation anxiety or, behaviors?
That's a good question. It's been a long time since I've looked back at it. I know that when you look at some of the published studies, the number is typically somewhere between 20 and 40% of the population, and maybe a little bit less on the referral side of things. I would again say that our numbers at the behavior clinic have gone down a little bit as the general practitioners have continued to take on more and more of those cases. So it's not nearly as common as it used to be, but I would guess probably somewhere in the 8 to 15% or so still, very much at the top of the list for those issues. And of course, we may get to this as well, but when we're talking about separation anxiety, we're kind of looking at a whole constellation of things that are coming into us for that as a quote unquote presumed diagnosis. Some of them are separation anxiety, some of them, as you know, are not at all what we're dealing with, but that's about the percentage I would say coming in for it.
Stacey,
so some of our listeners are trainers who specialize in separation related behaviors, and some of our listeners are pet parents who have dogs that are struggling with being home alone. So I just wanted to kind of frame that so that that you're talking to kind of multiple audiences here. For pet parents, and then also for practitioners working with separation related behavior cases, when do you think, or can you give some guidance or guidelines as to when somebody might go to their primary care vet versus a vet behaviorist, and when a trainer or behaviorist might reach out to a vet behaviorist for additional support, just to kind of, I don't know, lay that groundwork for people?
It's a good question, and I think it's often one of the things that I think gets a little bit, well, I think it's misunderstood a little bit. I think in some cases there's sort of this feeling of, I'll start with the vet, I'll start with the trainer, and if we don't get anywhere, if it's really, really bad, and we're going all in, then we're going to consider a referral or pulling in that perspective. And certainly that is some of the cases that we see. But, quite honestly, what I love is whenever I'm working with either a trainer or behavior consultant or a veterinarian or that pet parent who basically says, I don't have the skill set to navigate all of the pieces that I think are relevant in this case. Quite honestly, the moment we say that behaviorist is potentially relevant. And the reason I say that is that as a vet behaviorist, my training includes the veterinary piece, so I can understand sort of the medical side and whether there's any other, diagnoses that may be factoring in, whether that be pain or what have you. And then there's the veterinary behaviorist side, so I really understand the prescribing piece. But I also have credentials as a behavior consultant, and so understanding where behavior mod piece really impacts the learning history of the animal, not only to really be able to dovetail closely with the work that the trainer and the behavior consultant is doing, but to be able to listen with empathy to the owner who's doing a tremendous amount of work and maybe really feeling a lot of emotional weight as it relates to what they're navigating. And, and at the end of the day, all of those things are in my toolbox. I don't need all of them for all of the cases that I see, especially when I'm working with someone who's, let's say, a certified separation anxiety trainer, where I can say, cool, tell me the protocol you're working on, tell me where you're getting a little bit stuck, and maybe I can, again, use that to understand the medical or medication side, but I don't necessarily have to go down that full road. But quite honestly, I have to understand it. I have to know everything about what you're doing, because again, that's what's going to fill in the blank for me of where does this patient actually need support. And again, that's why I say it's not about just saying, what do we do for separation anxiety? It's, just as it's like, well, number one, we confirm what is it, what are we actually working with, and what is this animal's baseline? What is it about their overall behavior pattern that's causing them to struggle? And where can we pull in some of the environmental management? Where can we pull in some of the behavior modification? Where can we potentially lean on medication to reduce some of that emotional arousal and allow them to make greater progress? So all of the things are in the toolbox. As soon as somebody doesn't know all of the things they're working with, gosh, I'm happy to tag in and work collaboratively at that point.
One of the things that I love about you, not that I know you personally, but I feel like I do sometimes because I've listened to a lot of your podcasts or speaking events. And one of the things I love is this team approach, this collaboration. And I guess as we don't always see that in the field with even, primary care vets or vet behaviorists that we're working with. And I think that can create a lot of conflict, not only in, gee, maybe I should hang on to this case a little longer before I refer it, but also I think with our clients, because if we're not working collaboratively, then sometimes there can be little things in the protocol that are inconsistent. And then so the client is left with this conflicting advice, they're going to have to choose one or the other. And that can create like a lot of stress. Like I've seen that a lot with my clients. And I guess I'm wondering if you can think of or advise us on a better way to form that connection or to, get that collaboration or team feeling with some of the vet behaviorists, knowing that vets and vet behaviorists are super busy. So also don't want to step on that.
Yeah, we should be able to solve all of that in about 37 seconds, maybe. We can unpack all.
Yeah.
Okay, good.
Yeah.
Okay, start the clock. Let's go. No, you're absolutely right, Stacey, and I hear that. I feel that. It's one of the things that I find really, really frustrating when I'm talking at training conferences or with behavior consultants, or even when talking with vet behaviorists, is that I often get that feeling like everybody's sort of working in their own little silo, and we're not always sharing that information. And it makes me sad because at least for me personally, when I see what's possible through those collaborations, what initially may feel like a little bit more work, perhaps, to create those relationships and to get that fluency and fluidity of communication. Oh my gosh, once we've established that, what we are able to do together in terms of the efficiency of communication, to be able to say, hey, Stacey, I've got a case that's coming your way. Here's what I've started. Here's what you need to know. Here you go. And it's a warm handoff to you. And then you're able to do some sessions and say, hey, here's where we've got progress. Here's where we're struggling. Back to you for a revisit, and we're able to get that dialogue going back and forth. So I really do support that process. And that's why it comes up so often for me within conversations like these. Honestly, I think when it comes to the early side of those collaborations, I think for me, it's a lot about expectation setting and asking questions. And I know, trust me when I say that, I know that not every veterinarian, not every vet behaviorist, not every trainer or behavior consultant really wants that collaboration. And so I often start even going down that path. My preferred working style is to work collaboratively with someone where I can do a warm handoff back and forth. Is that congruent with your working style? Just need to know so that I can really kind of figure out how to work collaboratively with you to the best of my ability. That way I'm not hoping for one thing and getting something very different. So I like asking that question right off the bat. If there is even a minuscule amount of interest in that collaboration, my follow-up question is usually, awesome, glad to hear it. What's the best way for me to communicate with you or to collaborate with you? If you could wave the magic wand, what does that look like? Are you getting my reports after every session? Do you want sort of a summary every 3 weeks, or just when the client has a concern? I can do a lot of things on my end. What works the best for you? So again, we're trying to set those expectations right from the get-go, keeping in mind that for a lot of veterinarians or vet behaviorists, or again, even trainers and behavior consultants who haven't necessarily developed a lot of practice working collaboratively, sometimes when we ask the question, hey, what does your ideal collaboration style look like? It's sort of like a blank stare. They're like, I don't know. So, I have to go into that too, in which case, if they don't know, then I can describe perhaps my ideal and say, okay, well, here's what I find to be really effective. Do you think that will work for you? Can we try it and maybe revisit after a case or two and see if we need to make any adjustments? So again, I think a lot of it for me is expectation setting, asking questions rather than making assumptions. And in the ideal world, creating those relationships before we're in crisis and we need to lean on them. Because dang, that is the hardest place for everybody to really think clearly. When you've got a client in crisis, they need to talk to the vet. The vet doesn't know who we're talking about. They've never met the dog. The dog can't get in for an assessment for another 7 weeks. We're running into walls right and left. So the more of those communication channels that we have already established, I find the more effective it is to be able to say, hey, here's how we can nuance that. So proactive creation of relationships also factors in there for me as well.
That's really refreshing to hear. And the other thing that you touched on was, which touched a nerve of me, or that's not the right word, but you said empathy with your with the clients, and you're building that relationship. And for us in our work, we also have that very much. We have to have that side of that compassion and empathy with our clients, because they're going through a lot, and they're very, very feeling guilty and stressed and all those things that, prisoners in their own home, all those things that come with having a dog with separation anxiety. But I did want to ask you, I know probably you're at the back end of this, but when do you think it's time to have that conversation with a dog owner with, separation anxiety about moving down the road of medication? Because there's always pushback. I mean, some of our clients are very open to it, but I would say more often than not, they're like, oh, I'm not doing that. No, I'm not putting my dog on drugs, etc., etc. So, yeah, what do you think?
Yeah, I think so. If I could pull out to the sort of overall population before we come back into the certified separation anxiety training population here, because I think for one or two reasons there's a big difference there. And the reason I say this, and I want to be really clear, is that my understanding of individuals working with one of you, the client has already made the commitment to not leave the animal alone for any longer than what the animal can truly comfortably tolerate. So it's a really important distinction, because if that's the case, and we have an animal who is not currently or in the future experiencing any significant degree of distress because of the separation anxiety or the isolation distress or whatever we're talking about, whatever sort of label we're putting on that based on the pattern in front of us, that often takes down some of the initial urgency for me. Again, doesn't necessarily eliminate it. And if I have a dog who also perhaps has generalized anxiety or has other fear-based behaviors, or generally speaking has really big feelings of lots of things and struggles to regulate emotional arousal, there may be other reasons why we would still be talking about medication. But truly for the separation anxiety patient, I'm a lot more conservative if that checkbox has already been checked. For so many of the clients who are not working with one of you, who are sort of struggling, who may be listening to this, even saying, hey, I'm not doing that, I've not been able to do that, or I'm inconsistently successful. The moment we have an animal who is going to be experiencing that re-traumatizing of that isolation or separation anxiety distress, first thing is, let's talk meds. Now, I want to make one little caveat here off to the side. When I say meds too, I'm certainly thinking about pharmaceuticals for sure. I'm also thinking about pheromones and supplements and nutraceuticals and probiotics, and in some cases dietary therapy and right? It's all of these things that we may sort of do or give or change in a way that may affect that emotional resilience or arousal level, such that we're having an easier time getting consistent access to the thinking part of the brain, such that we're able to move our behavior modification process forward more consistently and reliably. So in those cases, again, yes, lots of options, lots of things that we can reach for. If there's an urgent need because the animal is going to be re-traumatized, then the moment we identify that, I'm ready to have the med conversation. I don't need to, quote unquote, see if it gets better with some interventions first. We are likely to make faster and more reliable progress by mitigating that panic response that's occurring each and every time the animal is over a threshold. What I love about what you just said too is there are so many ways to approach this. Right? There's nothing about this that says there's only one way forward. And what I love about that, it's also true when I'm thinking about the vet behavior piece, is that somebody may say, well, the individual that I reached out to at one point in time didn't exactly give me that warm fuzzy with regard to collaboration. Cool, let's find someone else. Right?
Mm-hmm.
Let's figure out what our relationships are going to look like. Let's figure out how we do that. And so, within this process, coming back to the big picture question about medication usage, again, if we've got an animal that's going to be going over a threshold, cool, let's talk meds. Not because I think that's the solution, but it may give us more of a window to allow the solution to take hold.
For sure. Yeah.
Do you have any advice, Dr. Pachel, for our listeners who are not working with somebody like us or a behaviourist, who want to approach their vets regarding medication but don't really know how to go about it, because obviously if you walk straight into a vet's and say, I want medication for my dog because it's got separation anxiety, most vets are going to go, no, it doesn't work that way. You need to do some training. But for some owners, they genuinely just don't have the ability or the finances in order to go forward with a behaviorist or even with a trainer for some people, and they're left with using books and using online initiatives and any training that they can find. And for those guys, getting hold of medication, which for them could be a real game changer, is going to be something really difficult. So do you have any advice for how they could approach that?
Absolutely, Sarah. That's such a great question. And I love really being able to cast that net wider, even still, where we're talking about someone who perhaps is working with someone like yourselves, or now kind of broadening it even further to that client who might be listening to this saying, hey, I'm going this alone and we're struggling. What might we be able to do? I find that a little bit of education can go a long way. And what I mean by that is if a client is struggling on their own, and I truly put those two things together, meaning a lot of clients are able to do a lot of really good work on their own and they're no longer struggling. And then there are people who, you get the idea, right? So the people who are doing what they need to do on their own and they're struggling, if we can get those individuals to have even a basic understanding of where medication fits into the picture, I think it's a lot easier to broach that question with a primary care practitioner who may be a bit resistant to reach for medication right from the get-go. So my approach when I'm talking about that with my clients or with veterinarians is to say, once we've got our diagnosis or our assessment or that working label that we've put on it as this is a separation anxiety related problem or a separation related behavior, and we're going down that pathway, we know that there's 3 prongs of the approach, right? Behavior modification is where the active learning and the true emotional work happens. In the meantime, or until we've been able to make that progress, of course, we're avoiding the triggers as best we can. And again, that comes back to something we were talking about before. And then if needed, either because I'm not making significant progress with the training I'm already doing, or I don't have the ability to completely avoid my animal's triggers, guess what? Big feelings are going to be getting in the way of making progress. And so if a client is able to come into a veterinarian, even with a quick little, hey, I get it, I'm doing the work, I'm avoiding, and we're still struggling, it gives the veterinarian, even if they don't have a huge understanding around separation anxiety, it gives them a role to be able to step into versus that immediate kind of pushback that you described, Sarah, of being like, whoa, you've got to do all this other stuff first. If the pet owner can come in and say, I get it. Yep. I'm not looking for meds as the solution. And I do think that it may be able to be a part of our way forward. It's a lot easier for veterinarians to hear that and then be able to work collaboratively with that client to say, okay, here are some of the things that we could do. And then ideally, that veterinarian is going to go down the route of asking a few more questions to figure out, are we talking about perhaps some situational meds where you only need to leave your dog home alone twice a month for 2 hours or less? Or are we in a situation where you're working outside of the home and it's 8-9 hours at a time, multiple days per week, in which case the situational meds are probably not good enough for long-term. So again, ideally, we've got a veterinarian who's got enough of an understanding of the toolbox to then apply the appropriate solution in collaboration with that client.
I was just thinking, I think you've done a podcast with the Canine Arthritis management guys, haven't you? Hannah Capon.
I think so. I don't. No, I'm going to be the one. Like I that sounds very familiar. I'm not going to lie.
Well,
I do a lot of things and I don't always remember them, depending on.
Well, we might cut that bit out then, but because they've got on their website, it's all about canine arthritis management, and they've got a small PDF tool that you can take to your vet that shows that you've been looking at the certain aspects of the behaviour around pain. So do you think it would be an idea for our pet parents to be able to give the vet something like that says, this is what I've done, this is a kind of like a very small written version of what's been going on, so that the vet can see some evidence of what's going on?
I think that's a great idea, Sarah. I do. And I'm not familiar with that tool, so that probably means that I was not the one who was working collaboratively with those individuals. With that being said, somebody was, and that's brilliant. So I will run with that. I will tell you what I do as a practitioner when I'm working with the trainers who work for me, either at the Animal Behavior Clinic or through my collaborative business through Instinct Dog Behavior and Training here in Portland, is that I typically have 4 questions. And I use the same framework every single time, truly, whether it's separation anxiety or a separation related problem or something else. And those 4 questions, whether it's to the client or the trainer or behavior consultant or even to the veterinarian, is always number 1, what are you seeing? Not what do you think is going on or what's your high level sort of interpretation. What are you actually seeing? What are your observations? Where, and what are you seeing? Number 2 is, what have you done? And this is the opportunity then to say, which exercises are we working with? How many sessions have we done if we're working with someone? How many sessions have we done on our own if we're doing that independently? But this is what I'm doing. The 3rd question is, and how is the animal responding? So I'm now starting to tap a little bit more into that learning history of the animal as well. If you're doing a little bit of work and making really tremendous progress, or the opposite, doing a lot of work and making very little progress, or crossing wires a bit and just not really connecting, that gives me an opportunity there with that 3rd question to identify that. And then the 4th one is a little bit more of the subjective piece. Where are you stuck? So it's really the opportunity to say, hey, I'm asking this question, in this case, about medication for separation anxiety because whatever that situation is. So again, it's the same 4 questions. What are you seeing? What are you doing? How's the animal responding? Where are you stuck? And I use that same 4 question framework over and over and over. And as the prescriber and or diagnostician, it really gives me the understanding of then saying, cool, I know how to sort of dovetail with that, either to give you some additional recommendations down, in terms of either management or behavior modification, or running additional diagnostic tests, or perhaps prescribing to be able to support that progress. So those are my 4 questions that I lean on. And I think utilizing that is a great way to start that conversation, as long as it's not 37 pages of answers.
I think it's a really nice, simple framework of questions, isn't it, that most owners can cope with 4 questions. When you've got question after question after question, that's when they get lost halfway and end up telling you all about Timmy and his toenail in 2004. So it's I like that. That's a really nice framework. Thank you.
Absolutely welcome. It's a great question. Anything that we can do to support those conversations, yes. I'm just all in. Yes, let's get that going, because there's not enough of you, there's not enough of me. People out there who are struggling need help, and whether it's the availability or whether there are other limitations, whether that be financial or some other limitation, oh my gosh, the more of those questions that we can utilize to really get those conversations going, the better off we are.
I have a question, and I don't know if this is in your kind of ballpark or not, but I'm just going to ask it, and if you don't know, then that's fine. But you know how when dogs are exposed to chronic stress or anxiety or fear or phobias or, whatever they're going through on a chronic basis, how it can change the brain. The amygdala gets larger, blah, blah, blah. When we help the dog feel safe, and are those changes reversed, or are those permanent, or do the medications help with that? Do you know?
Very good question. I love this. I was like, ooh, we get into some good stuff. Yes. So I love that question and coming at it from a couple of different angles here. I mean, yes, everything that you mentioned with regard to either acute trauma, sort of capital T trauma that happens at sort of early developmentally or later in life. As we're learning more and more, we understand that it does a lot of different things. And I'm going to be really general about that right now because it really depends, even on the humans where it's been studied the most, it depends on the age. It depends on the social support that exists for the individual. It depends on the specific type of trauma, even as to how that really sort of manifests within the body and where that may exhibit or elicit some of those changes. So, that's on sort of the trauma side of things, and we could differentiate that with acute trauma versus chronic stress or recurrent trauma and, run down all of those individual pathways. When it comes to the second part of the question, which is, well, and then what happens, in terms of those brain changes, I haven't seen nearly as much research on that side. But there are two things that come to mind for me that may help to shed some light there. The first is, a lot of those brain changes when we're talking about the limbic system and some of those structures like the amygdala, like you mentioned, those changes are adaptive, meaning they are the body's response to stress. And the reason why that sticks in my head a little bit is that even if the animal now goes on to feel safe, they now have coping strategies, they have skills that they can lean on. I would argue that the body is probably going to hold on to some of that trauma somewhere in the body because it happened once, it might happen again.
Mhm.
And so I wouldn't expect it, just like we know that when we're working through a behavior modification protocol, we're layering in new experiences and new associations. We're not erasing the pre-existing ones. And so
Right.
my suspicion is that if we were to really dive in there from a neurophysiology, neurochemical, neurobiology standpoint, we would probably see that at least the core of those changes sticks with us. That's my suspicion. With that being said, let's come back to the third part of your question, which is really where my toolbox starts to shine, is that we know with some of the medication types, specifically some of the longer acting medications like the antidepressants or those that have more of a long acting effect on not just sort of what's in the bloodstream right now after I've given a pill, but some of those long-term changes, we are able to actually encourage or initiate neurogenesis or the development of new brain cells in certain key regions. So we know that when we get it right, we are actually transforming the brain in new ways, not necessarily just mitigating or erasing the effects of trauma, but we're actually feeding forward in the development of new coping pathways. And so it's one of the reasons why I tend to not shy away from the use of medication when I have an animal who's struggling, is that it's not just about giving them something in the moment that has the potential to decrease that panic. It's actually about onboarding a tool that may facilitate long-lasting changes within the brain that sets them up for long-term success. So it's a long-winded answer to a very, very detailed question, but how does that land for what you were wondering about there, Stacey?
No, I like that. I mean, I wish that the answer was sure, we can reverse those changes, but but I do think that now that when you were speaking about the new brain cells being formed, I think I do remember reading a paper about how it increases the plasticity of the cells as well. Is that right? Or am I making that up?
No, you're absolutely on the right track. And we used to think, in many ways that the brain, once it had matured, it was sort of like this rigid plastic almost, borrowing the plasticity word here for just a second, and being like it's this rigid, like it is what it is, we can't do anything about it. And it's like, no, like the brain continues to remodel both in sort of positive and negative ways, whether that's in response to trauma or whether it's in response to learning or in response to medication effects. And again, caveat when I say medication, big umbrella with all of those things within it. everything that we're doing to really help that animal move forward has the potential to impact that. So it's very, very much something where we're, by leaning into that neural plasticity, we're ideally trying to, and again, this depends on sort of where we are in the developmental phase of the animal as well, is we're ideally trying to strengthen some of those synaptic connections that allow the animal to regulate, well, in our cases here, the emotional arousal more effectively, rather than tipping into more of the fight flight sort of emotional responses that can be problematic.
So with my clients, I try to explain it in this way, and you tell me if I've got it right. But so we've got the trauma here, and I try to maybe use the analogy of PTSD. So we've got these neural pathways that are not happy, and we're trying to build new neural pathways, but the old ones are always still going to be there. But when we're building these new neural pathways, we're also building myelin. I don't know if that's how you pronounce it, myelin, M-Y-E-L-I-N. And that's kind of enveloping or, covering the neural pathways, and that should be getting thicker and thicker and thicker with more and more safe absences for the dog. So even though those old ones are still there, we're building up this, and we're creating more myelin to protect the dog and help it understand that, being home alone is not scary and it's safe, etc., etc. But because the old ones are still there, then we have regression and variability in training. And so if you draw the comparison to somebody with PTSD that's maybe seeing a therapist or something like that, and they could be doing really, really well and they're recovering, but every now and then they have a crappy week or a bad day and they're back here in the old neural pathways. Does that sort of resonate with you?
It does. No, I think we're absolutely right, right in the ballpark here. There are a couple of things that for me, I tend to skew in a slightly different direction, just because PTSD is something that's a very specific condition in and of itself. And there are very specific conditions, especially when we're talking about humans, for example, where that diagnosis was really developed, and some of the intrusive thought patterns and some of the flashbacks and some of the fragmentation of memory and some of the things that are a direct response to that type of trauma, to me, limits our ability to really think about that in terms of its universal application across all trauma. So I tend to pull back a little bit on the PTSD side of the explanation, but everything else that you're saying about sort of those well-established communication pathways and sort of the need to establish new pathways. Sometimes I'll describe it to clients as well. And I think this kind of captures the kind of the myelin piece that you're bringing here as well, is that it's almost like if we sort of compared the brain in all of its complexity to a jungle, for example, a really dense jungle, and there's a path through. Well, the easy way to move forward is to follow the path that already exists. And so the brain will do the same thing. It's the efficient way to do that. The brain is inherently not a terribly efficient organ. And so if there's a simple, already established way to process or to get from point A to point B, the brain will most likely do that. On the other hand, if we grab our machete and we start cutting our way through the jungle because we need to make a new path, initially it's going to be a little bit rough, and it's going to be really tempting for our brain to kind of jump back onto the old established pathway because, gosh, that's a whole lot easier. It takes a whole lot less work, and the brain actually kind of wants to do that, especially when we get tired. And so we see that pattern within our canine learners as well. It's like we're doing great, and then we missed a couple nights of sleep because the baby was colicky, and we're right back in there. Whether that's re-traumatizing or whether it's like the brain's like, you know what? No, I can't make these new pathways right now. I don't have the spoons to sort of draw on that analogy as well to say I just can't do that. So we get that sort of regression back to those existing pathways. So a lot of what we're trying to do in many ways with medication, if you will, is make it easier to form some of those new connections and to make it easier to sort of, well, deepen the groove, deepen the path, ease the communication through these new pathways such that we're not quite as likely to revert back to the old ones. So, again, every client's going to hear that a little bit differently in terms of the explanations, but we're talking about kind of the same thing, right? That tendency to regression, the difficulty of new, and some of that nonlinear progress while we're establishing new pathways.
I love that analogy, the jungle.
I use that one too, but it's not a jungle, it's a forest, and it's hiking. So, you know, but kind of similar. So, I mean, I guess I'm having a thought, but I'm not like sure how it's connecting. So I'm just going to say it, and then maybe we can make it connect together. My thought is that when we're looking at factors that may contribute to a dog's ability to feel comfortable home alone, and what I'm thinking here is like if there's also pain or allergies or chronic ear infections or, you know, any of those things that could maybe contribute. I guess what I'm wondering is just kind of increasing their baseline of maybe stress on their body, and so they're not as able to handle, so it's harder for them to choose that new neuro pathway or path through the jungle that you're macheting, or is it more of like trigger stacking ish feel, or what do you think's going on there?
Yes, all of the things. Yes, I think that it's probably truly all of the things at various times for different learners across their lifetime. I think in some cases we can really think about something like trigger stacking, where we're talking about the simultaneous layering on of multiple stressors that essentially exceeds the animal's ability to cope in that moment. And we see then them tipping more into defensive, emotional arousal, something going down that pathway. I think there are also cases as where I would say it feels or appears based on the assessment less about multi-dimensional layering in a particular moment and more about perhaps even the chronic influence of, let's say, chronic pain on the animal's ability to truly, as best we can measure it, feel safe. Because there is a sense of danger. If we think about survival skills, if the animal's not at, peak wellness or fitness, you have to be more aware, you have to be more mindful of how you're going to gather or acquire resources. Safety becomes more important because your body needs to rest and recharge and recover. And so there's this chronic impact. And again, I'm being a bit general here too, because whether we go down the pathway of talking about cortisol or whether we're talking about any of the other components within the brain or the body, it all matters. And it's super complicated as to what exactly is happening. But the net effect, generally speaking, is that the more of those factors we have, or the more chronic those factors are, the harder it is for the animal to operate from a place of safety, security, curiosity, creativity, even if we're going down some of those pathways, and especially if we're doing any sort of training exercises that involves free shaping or capturing of behaviors. I think we've all worked with those learners where they're operating from a place of stress and it is just not safe to guess.
Right.
It's just not safe, right? And so we see those patterns, and whether that's coming because of the emotional perception of danger or whether it's a physical element, I do find that for many of my cases, it's difficult to tease those out. And that's why really working hand in hand with veterinary teams to be able to evaluate for those factors is such a huge, important part, as all of you know.
So
and then on,
go on.
I was going to say, and then on top of that, on top of the animal state of mind, you've then got the poor pet parent state of mind, who are also falling apart because they can't leave Ernie at home for 10 minutes. How much of that do you actually get when you go and learn about behavior? How much of human behavior is part of that learning, or isn't? Is that something that you then have to go and do on your own?
Yeah, it's something that we definitely get exposed to varying degrees. There's a core of it that's necessary in terms of understanding how those pieces may influence. I am the last one who would say, oh, I have the equivalent education as a marriage and family therapist or a veterinary social worker or a clinical psychologist or no, that's all above my pay grade when it really comes to navigating the client through some of those dilemmas. And yet I've worked in combination and collaboration with veterinary social workers for the better part of my career to be able to say, hey, I think there's something going on here that I can't quite put my finger on, but it feels more or different than quote unquote the normal stress. You
Mm.
know, how might we evaluate that? How might we dig in here? I worry that this may be having an impact either on the client's ability to hear and implement or the ability to be consistent. Or in some cases, I've worked with clients over the years, and I say this 100% without judgment, who, they're coming back to the empathy piece, who really identify with the role of being a caregiver and that feeling of being needed by their companion animal may actually be filling a really important role within their life. And
Mm.
I've had some cases over my career that as we start to fix, quote unquote, fix the separation anxiety, and the animal starts to develop a greater feeling of independence. I've had some
Mm,
clients who have been able to acknowledge I actually don't feel as needed anymore. And that's a
Mm.
terrifying identity crisis for me. At which point I have to be able to acknowledge that's a part of our picture. But again, it's not something that I have the skill set to then say, oh, well, now we're going to navigate that in this way. Nope, nope, I can't do that. But back to your question, yes, we have to have enough of an awareness of how those patterns may show up to
Mm.
not only recognize when they are a factor, but then to also get through a lot of the mythology out there that, that says, oh my gosh, if you have anxiety, therefore your animal is going to be anxiety. So it stands to reason that your pet is dysfunctional, or some of those sort of labels that get put on that aren't helpful, that just are not
right.
helpful to hear. And so we have to be able to unpack some of that as well and say, no, 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 this is from the animal's perspective. This is what we can do. Here's how we go forward.
Mm.
Yeah, I've definitely struck clients that that have struggled with their dog becoming more independent, not in a bad way, almost in a bittersweet way. Oh, he's not under my feet anymore. He's gone off into the other room and I miss him. I'm so used to him being under my feet. Yeah. So it's the ones I've had at least have been quite happy about the progress, but a bit sad as well. But not.
Yeah, I think it's a real thing. It's a real thing. And, I think it stands to reason, because anytime you have a relationship and then the dynamics of that shifts in some way, there's a time of kind of redefining that could feel really uncomfortable, right?
Yes.
And so it just is what it is. But I think that, sometimes it is something that we go ahead and pass on to, like, oh, is there something, do you think you could benefit from talking to a counselor or a psychologist, or, just suggesting, here are some other ways you can connect with your dog, depending on kind of the depth of the distress going on there. But yeah, that can be tricky. And I actually kind of see it a lot to varying degrees. I think it might be just kind of a normal part of the whole thing.
And whether we call it grief or sadness or relationship restructuring, and and just the discomfort of this being new and unfamiliar in our collective learning history, that's a lot. Like, there's a lot of stuff that's going on here. We're not just, again, I'll say fixing, always in the quote unquote fixing. We're not just fixing separation related problems, and it's this one little tiny part of that animal. It's a relationship changer in a lot of cases where there is a level of dependency on that owner or caregiver's presence. And that does change the relationship. And I think, again, even if it's not my job per se to dive into that and really support the client through their journey through, doesn't mean I can't acknowledge it.
Right.
And and my approach is typically, as I suspect each of you do something very similar, just to echo it back. I can hear that this is hard. I can hear that this is hard. Do you have a support network or someone that you can reach out to help provide you the support that you need to keep going through this? I can help support the work, but I'm not necessarily qualified or credentialed to support you. I'll do my best, but I have to be really clear where my professional role is. Do you have someone you can reach out to? If not, if I had some resources for you, would you be interested in taking a look? And and it's sort of just offering, I don't want to say necessarily a lifeline, it's not always that dramatic, but the opportunity for clients and pet parents to really be seen and heard in the struggle that they're going through, even if I'm not the one to fix that for them. Oh my gosh, I can still
think
acknowledge
it's huge.
how hard it is.
I think that's huge because so many people that are working through behavior problems with their dog, whether it's separation related behaviors or reactivity in quotes, they feel isolated and alone. And if you can just say, I hear you, you are not alone, even if you don't have anything to make it better, I think just feeling understood is giant, and making that connection is a big thing.
Absolutely. And I think, I've learned over the years, again, in working alongside social workers in particular who have those skills as part of, that is much of what they do. I've learned how to maintain those boundaries for myself as the practitioner as well. I can acknowledge, yes, this is hard. I can tell, and I feel your struggle, and I'm not a therapist. And there's sort of there's a period at the end of the sentence, right? It's not, but I'm going to do what I can to help you. And I really want to it's like, no,
I think for me,
it's hard.
I really enjoy helping people and coaching people, and that just is a big reason of why I do what I do. And I think the thing that really helps me have those boundaries is knowing what resources are out there. Because if I know that I'm not equipped to do it, but there's somebody who is, fabulous. I am happy to, but if I'm not equipped to do it and I don't know of anybody else who is, then I get that feeling that I don't know, burden's the wrong word, but like a heaviness, because I know you need help and I don't know how to get you that help. Right. And so I think one of the things that's really important for us is to have those connections and know where those resources are, so we don't get put kind of get that fatigue ourselves and then not being able to care for you or our clients in the way that we're actually equipped to. Right. So anyways,
it's really relevant, Stacey. I'm glad that we're getting into this, because I think that, especially for those professionals who are listening, who are often navigating some really difficult scenarios, and there's a lot of weight. There's a lot that hangs in the balance based on our ability to show up and support and help and do all those things. It's actually really easy for helpers of the world to basically, help by offloading the client stress onto ourselves. Here, let me carry that for you, because no, we actually can't do that. That's not sustainable. And it reminds me, when I had some of my early conversations with a social worker who's a dear friend of mine. I remember that this was back in probably 2004, 2005, and she said, "Well, if you don't mind me asking, I'm just learning about the veterinary behavior world." And she said, "How many active patients are you allowed to keep at any point in time?" And I was like, "Well, I don't understand the question." She was like, "Well, how many active patients do you have?" And I was like, "Well, all of them." Like, anybody who needs me. And she was like, no, no, no. In the, and at least at that point in time, in her world, that you could only have a certain number of active clients, because they knew that beyond that, whether it's 30 or 70 or whatever that number is, beyond that, your ability to be able to offload the stress that you are experiencing with secondary trauma starts to really decrease. And I was like, oh no, we don't have any of those boundaries. And she was like, okay. So second question, after how many consulting hours are you yourself required to work through therapy? And I was like,
Wow.
again, I don't understand your question. I was like, never. There's no requirement for me to actually develop coping skills. And she was like, oh my God.
That's
Oh,
crazy.
you have no limit in the number of clients, and there's no requirement that you actually are getting help yourself. Oh my God. And that was I remember her face as clear as it was yesterday. And it stuck with me. And I carry that forward, even though we still don't have any of those parameters in our disciplines and within training and behavior consulting and, within separation anxiety treatment either. But there is a reality to that. And us as individuals need to understand we have limits. It doesn't mean that we ever have limits to our empathy, but in terms of what we can actually do, there is a finite point at which our level of resilience is not sustainable unless we've also been able to set some of those boundaries. And so, again, when I talk about those things, as we were talking about earlier, of being able to hear the struggle and also put periods at the end of sentences, that to me was part of my response to that, to be able to say, I hear you. I really wish that I had more to offer you. And I don't. I don't. And then to be able to figure out, okay, now what do I do with that? Comes back to what you were saying about making sure that we know the resources as best they exist in our communities.
Right.
I will say, this is the last thing I'll say on this particular topic too. I am grateful for so much of what has happened over the last couple of years with regard to globalization of resources when it comes to support and online education and all of those variables. Meaning, again, I'm not grateful for many of the other things that we've all had to endure over the last couple of years, but that need has really created an opportunity. And so whether it's for separation anxiety, whether it's for therapists to be able to connect with clients who live, remotely from where they themselves are, there are more resources than there were. And I think that's amazing.
Yeah, it really is amazing. So while we're on this subject, this is a question that I definitely wanted to ask you. Do you take worldwide clients, remote clients within the US? Like, how does that all work? And stuff.
Yeah. So we can do that a couple of different ways. So the first thing that I'll mention, which is the easiest on our end here at the Animal Behavior Clinic, is doing vet-to-vet consultations, which is typically up to a 30-minute conversation with the veterinarian, whether they're a specialist or whether they're a primary practitioner, doesn't matter. Someone who is licensed in the area where they are actively treating a patient that they have a valid client-patient relationship with. And I'm basically acting as the consultant over the phone. They're asking questions. We might be working through some version of those same questions that we talked about earlier. But something there where they're able to say, hey, I've got this case, I'm not quite sure where to go. Then I'm able to talk professional to professional. We can do that with folks around the world. There's no limitation on that, peer-to-peer. The only limitation that we have encountered thus far has either been, where are we in the world in regard to our time availability and how, connecting with someone at 2 a.m. where they happen to be, for example. And then the second is more of a language barrier. If I'm almost embarrassed to say I only speak English. That's all I've got. I don't have another tool. I've used some of the translation devices, but when we get into the nuance of what needs to happen for behavior and medical stuff, I do not trust it. So I need the individual on the other end of the line to also have fluency in English. again, I hate to say that's a requirement on my end, but that's one thing. And we can do that around the world as long as those conditions are met. We also have the ability, this we do mostly within the US just from a logistics standpoint, but potentially could branch out a little bit case by case basis, is to be able to do an initial assessment, phone call, video conference with the client to gather that information so that my team, who understands how to do this infinitely well, is able to gather that information and then relay those recommendations to the primary care provider, who again has that relationship with them. Those are more typical, more reminiscent of a standard consultation that's more in the 60, 75 to 90-minute range that gets into a lot of the other details, and we're looking at other differential diagnoses and those sorts of things. In that role, myself or my team members, we are not the one who's the diagnoser. We are not the prescriber. We're getting those recommendations again back to the primary care team. But that is something that is also available. Again, we've done that primarily with practitioners in and around the US, and we've got a process for how to onboard those clients and how to support them and work with the veterinary team. So yes, we definitely have options.
And so if, like, for example, I were to refer one of my clients to you, then what would be the best way for me to reach out and let y'all, well, they would reach out and schedule the appointment, but what would be the best way for me to reach out and say, hey, this is what we're doing, this is where we are, this is what we're, these are our obstacles, help?
Yes. So once the appointment gets scheduled, and my team is able to walk them through that, basically when we have a client who calls and says, hey, I'm looking to schedule an appointment, they've got a couple of questions that they'll ask to figure out which is the appointment type. Are you within our area? Is this an out of area consultation, or are we doing the vet to vet consult? How are we going forward? From there, then typically once that gets scheduled, then we are more than happy to accept any additional resources, whether that be short video clips, whether it be succinct training reports, something that again basically says, this is what I'm seeing, this is what we're doing, this is how the animal's responding, this is where we're stuck, here you go. We love getting that information. I will tell you that for my doctors, my veterinarians, we are often prepping those cases. Our team does a lot of the stuff in the background, but we're not necessarily doing the deep dive on that individual case till sometimes the morning of, or within 1 to 2 days prior to that consult. So really a lot of that communication on the front hand is really the more of that you all can take care of to get that information into us for review and for consideration, the better. Meaning once I open up that chart, I'm going, oh my gosh, they've been working with Stacey. I wish I had reached out to get an update. It's too late. I'm heading into the consult in an hour and a half. Like it's just not an option.
Right.
So the more of that you can do on the front end at the time of making the referrals, better off we are.
Cool. Yeah. Very good. I know we got off this subject, but I wanted to kind of steer us back because it is something I'm really curious about your take on. We talked about the brain changes, and I know some of those changes are happening developmentally as well. So sometimes there seems to be like a camp of dogs under the age of fill in the blank, 6 months, a year, should not be on any medication, or another camp saying, no, it's super important that they are because that's when the brain is developing. And so can you kind of talk to us a little bit more about that?
Yeah, and they're both, I would say both of those camps are right, depending on the case in front of them. Right. Okay. So when I have a particular case that gets discussed in one of my psychopharmacology lectures when I'm lecturing at a couple of the vet schools here in the US or at different conferences, and it's a youngster who came in to me at about 3 months. He was a little male at that point, intact Australian Shepherd, who at 3 months, 4 months, I forget now, was already working with a really skilled trainer, behavior consultant in our area, And so we had the advantage of being able to fill in the blanks of this is what we're seeing, this is what we've done, this is where the animal is not responding, here's where we're stuck. And so in that case, I had no hesitation at 3 to 4 months to say, you're doing the work. His brain is not going to get more flexible as we go forward from here. If we don't do something different from what you're already doing, I'm not sure that you're going to be successful. And I do really worry about his learning trajectory. So he was started on medication at 4 months. Now, for the individual who comes into me, so let's say the client goes to the shelter, whatever the organization is, or through the paper, and they now have a brand new 6-month-old dog in their household. They leave to go to the store, they come back and there's been destruction. We have a singular episode, we haven't done anything yet, I don't know what the animal is capable of learning, and I'm not even sure that we are in fact stuck.
Right.
Would I be reaching for medication in that case? No, we've got to do our due diligence. We've got to figure out, do we in fact have a problem? To what degree would medication be relevant here? So like for me, I think when I hear those folks who are saying 6 months old, how could you possibly go down that pathway? I'm thinking more about that second case. For the folks who are advocating, oh, we could absolutely do that, I think they're thinking more about the first case. And so they're both right, depending on the animal that's in front of them at the time. And the trick, if there is one, is to be able to tease out who's in front of you.
Right.
That makes sense.
I like that.
I mean, I know some people think, oh, that person is, e.g., a surgeon, so they always want to kind of cut somebody open, but that's not necessarily the case for surgeons. So to think maybe that a VB is always going to prescribe medication is incorrect as well. So, yeah.
I'm glad you mentioned that, Ness, because it is one of the misconceptions that I think is so common. It's like, unless a client is looking for meds, why would you ever go to a VB? Right. And I'm like, oh my gosh, like it's a big part of my toolbox. Of course, it's a huge piece that I have a really unique access to. But I got all the other tools too. And part of having that big toolbox is assessing when and if and what might be relevant, versus saying you've got separation anxiety, so therefore here is the prescription that you all walk away with. Not on my watch. That's not how I'm looking at it. What's the need? What are we trying to accomplish? And even more than that, how are we assessing whether or not it's making a difference? What are our parameters, which I know all of you do such a phenomenal job of gathering data and helping their clients through that. So we get these, really awesome data points to be able to say, oh, here's when the meds changed, and here is what that looked like then in terms of our ability to have calm departures and blah, 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 blah. So that collaboration is there, but I'm so much more than a prescriber in terms of what we can do.
I have to ask too.
To get a T-shirt.
More than a prescriber.
The clients that are worried about giving medication to their dogs, I mean, can we say, some dogs, I guess, with generalized anxiety might need to be on it for long term, but if we're just going through a training protocol with the aid of medication to facilitate that training, do they need to be on it forever? I mean,
it's a good question. And there's two things that I really try to address for concerned clients up front. Number one is their concerns are valid, right? We do see patients who respond poorly to medication, which is one of the reasons why I never think about it as simply, oh, we're just going to medicate for X, Y, and Z conditions, because it doesn't always work the way we want it to in that regard. So yes, it is possible that we could see side effects. I'm not going to sugarcoat that and say that we won't or that we can't. So again, I'm going to hear your concerns. Which of the side effects are you aware of? Are they valid for the direction that I think we might want to go from a medication standpoint? And then what are the strategies that we can use to reduce the likelihood of that? Slowly onboarding, perhaps test doses or whatever the case may be, right? So validating their concerns and giving a framework of how we can deal with that. The second part of it really then is the timeline. And that really depends on what we're using and what other conditions may or may not be present. So if we're talking about a situational medication that's being used twice per month to keep the animal freer of panic, not necessarily obliterating that panic response, but helping them to be more comfortable when we need to exceed their threshold even a little bit, that's one of the things that we can do. And gosh, as soon as we don't need that support anymore, awesome, that scaffolding for our plan just goes right away and we don't even think twice about it. And if we're talking about a patient that is benefiting from a longer term medication, thinking there about perhaps some of the antidepressant type options that are available, generally those take a good solid 3, 4, 6, 8, somewhere in there, weeks to really take effect. And we're often reaching for them because we have an animal in front of us who has been struggling. So we're going to utilize those medications until they're no longer needed and then pull away that scaffolding baby step by baby step by baby step to see whether or not that learner has the ability, the capacity to continue going forward down the path that we've created for them, or are they still benefiting from that medication support along the way? And I do have some of my clients at that point in time, especially when it's taken us a very, very long time to get to that point of success, where they look at me and they say, I can't. I know it's possible to take the medication away, but I just can't. The thought of going backwards right now, I just can't do it. I'm like, okay, that's cool. As long as we're checking our blood work and we're evaluating for health, that's generally fine. But I also don't want clients making the assumption that because we've started the medication, we are now sort of committing to a lifelong usage of that. This is very much an individualized process. It depends on the medication type, the patient response, and honestly, how much work the client is putting in, or whoever the caregiver happens to be, how much work are they doing to actually onboard that set of coping skills. And that's in some cases, I will say, in full transparency, it's one of the places that I worry sometimes about pulling in medication prematurely before we've really figured out what the need might be for that patient, is that we may end up with an owner who sort of recognizes the benefit of meds, and then their motivation to actually do some of the training work really starts to go down. I'm like, no, this was our way in, but it wasn't the solution. No, we got to do the work. Otherwise, we are probably going to be stuck with lifelong usage. If we're not doing the training, we can't expect the animal to just magically learn new skills.
Okay. Go Stacey.
No, go.
Oh, Sarah, were you gonna? No. I have a question then, Dr. Pachel, Dr. P. It's before you mentioned about diet, taking a holistic approach. So, you're talking about diet and pheromones and probiotics, et cetera. Now we know the new kid on the block, there's always some fad sort of thing, isn't there, going around, and the new kid on the block is CBD oil. And I was actually lucky enough last night to attend a webinar. It was called The Therapeutic Scope of Medical Cannabis in Australian Veterinary Practice. So they had two vets on in Australia, Australian vets, one of them sort of focusing more on the physical benefits of cannabis oil, but the other one was focused on cancer was one of the things, but also anxiety and separation anxiety. What do you see? Obviously, we need more research. There's not enough there. It's not, and the research has been done, probably isn't robust enough, etc. But what, if any, do you see as a role of medical cannabis? Is it something you've used? Is it something you would consider using, or are you sort of more heading towards the more prescribed pharmaceutical medication?
It's a great question, and it definitely is one that comes up a lot, especially. So I'm in Oregon on the west coast of the United States, and cannabis in essentially all of its forms is completely a part of our culture here. Right. So it's what are we gonna do? Like, how does that work? I will say that my concern, there's a couple of things. Overall, I would say that my clinical impression of I'm going to make a big umbrella with my hands here of CBD as sort of like the whole scope, the whole spectrum. I'm pretty darn underwhelmed. I have not been particularly impressed with the responses. Now, that comes with some really important caveats for me. One, at least here in the population, with the cases that I'm managing, I get clients literally every single day. Oh, we tried CBD, it either worked or it didn't. And so what we get is a lot of anecdotal reports on 942 different formulations with 1,800 different purity and concentration and distribution model strains, and just I get it. It is such a scatter plot of data that I can't even begin to draw a meaningful conclusion as to, is it helpful? If something within there is helpful, which one and for what? So I think that from that standpoint, I think we're really premature to know what may be helpful. I do sometimes get clients, they've lucked onto a product that they feel is helpful, especially on a situational basis. So I'm not discounting the possibility of it working. The piece where I start to feel really uncomfortable, Stacey, I'm kind of echoing back to something you said earlier. Like, as soon as I'm like, but I'm a helper, and I feel like if I'm going to give you a recommendation, I feel like I should have something tangible to be able to be like, here, give this at this dose, and this is what we're looking for. And I don't have anything of the sort when it comes to this. And we also know that at least here in the US, many of the CBD products are not inexpensive. And so it becomes a really big challenge. Do I send the client to the pet supply store or the weed shop down the street, literally, for all of the pet products that they have available there too, and have them running through literally hundreds to thousands of dollars to try all of these options when I actually know exactly what I'm looking for with the pharmaceutical? I'm not saying necessarily that the pharmaceutical effect is inherently better, but I know what I'm looking for, and I know how to navigate the side effects, and I know when to tell you when it's not working and we need to do something different. So as a prescriber, that level of clarity is really important for me. I am looking forward to some of the additional published research that I know is ongoing with some of the companies here in the US and around the world as well, to at least be able to say, here is a product that at this dosage, when given this far in advance of a departure, for example, is likely to have this magnitude of effect. Gosh, as soon as we've got that to some degree of reliability, at least I'll have something to fill in that blank. Here in the US, we also have the concern too that there's a lot of discrepancy around what veterinarians are actually allowed to talk about in terms of federal versus state licensure, and whose authority allows us to talk about controlled substances as veterinary prescribers where it's not technically under our license. And so it's really awkward in that, I'm gonna say the high school kid down the street at the weed shop has the authority to talk about cannabis, but I don't. It's a really weird scenario. So long-winded answer, currently underwhelmed, hopeful for the future. I don't have a good answer yet.
Yeah, it's really interesting because, so many of our clients, or, you jump into the Facebook groups and everyone's saying, oh, try hemp chews and CBD and blah, 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 but they're not getting them off, they're getting them off. They don't know what content's in there. They don't know how much CBD's in there. They don't know how much THC's in there. They don't know what's activated, blah, blah, blah. The good thing that I did like about this webinar last night was they were saying, this is, if you go down, a proper prescribed compounding chemist that's vet prescribed, then you know exactly how much THC is in there, you know exactly how much CBD oil is in there. And they had, for X amount of, milligrams per kilogram of dog's weight. And it was very structured. But, unfortunately, a lot of I don't know, guys, I don't know how many of your clients have used it, but I know in my Facebook group, I see a lot of people saying, oh, I've used it, it didn't work, or I used it does work. And it's so anecdotal and it's so unclear about its efficacy.
Well, I think the other thing is, and correct me if I'm wrong, that there can be some drug interactions where it will magnify or reduce the effectiveness of, like, if they're also on a prescribed medication. So I think a lot of people just say, well, I can buy it at the store, so I'm just going to buy it and add it to what's already going on, not realizing that it can mess things up. It can have the opposite effect of what they're intending on.
And you're absolutely right, Stacey, that there's the possibility of that. I have not seen much in the way of those interactions clinically to be like, ooh, 9 out of 10 times I run into a problem. It's really been hit or miss. And then again, the question is, what did they take, and was that the problem? But your point is a good one, in that there are potential safety interactions that we just don't know about. And so I think there's often a perception that, because it's, quote unquote natural, or it's available over the counter without a prescription, therefore it's benign unless it helps. And that's not necessarily the case. None of these compounds, basically, if it has the potential to impact emotion and brain function, it's not benign.
Mm-hmm.
That's why we're reaching for it, is because it's not benign. Right?
Right.
It supposedly does something. So I really try to hone that, not to scare folks, but really to say, hey, we don't know. We really don't know. And I don't want to just throw a bunch of things, especially when we're looking at, the animals in front of us. I know that people are coming at it from a place of caring and wanting things to be better and hoping that it works. And I full support for that. I mean, yes, absolutely. And I just don't know.
I guess for me, one of the big problems with working things like that are a big question mark, unknown, or whether they have been tested and the results are kind of iffy. It's another thing that your client spent money on, and it's another thing that your client tried and didn't work. So it just adds to that burnout. So I'm with you. I would rather like them go with the things that have been on the market, have been tested, and all of that, just to.
And as a prescriber, I mean, the struggle is real. I mean, I actually have the similar reaction. Not that we're going to go down the route of transdermal medications here, but we know that there are, for certain types of medications, we don't always get a real reliable effect. And again, if I'm talking about oral administration of a supplement or a product or a pharmaceutical, and I know exactly what I'm aiming for, if I get a patient who is giving me, let's say, a partial response, I know what to do with that. I know whether to push forward, whether to pull back. The CBD piece, again, I've got sort of this, maybe it's helpful, maybe it's not. I don't know what the dose is. What am I looking for? When should I give it? Do I have to give it the night before, or is it the morning of? Is it 3 minutes before? Is it 3 hours before? Do I have to give it twice a day? I don't know. I just don't know. Good luck.
Big question mark. Yeah, it's a worthwhile discussion purely because it's a fad at the moment. So we need to discuss it. But yeah, again, for me, there's not enough information. Yeah.
I agree.
I find it fascinating that for our clients, how many of them would go down the route of what was at some point in a lot of places an illegal drug over a prescribed medication. It's bizarre, isn't it?
It is. I remember sitting in on a pharmacology lecture. Gosh, this would have been probably back in 2006. And the pharmacist was, kind of sharing some of the data points basically, and comparing a couple of different drugs. And he was making the claim at that point, or the comment at that point, I believe he was talking about something like St. John's wort or something more on the herbal side of things that also impact serotonin levels, and drawing sort of like, when we're having even that conversation where we think we know what we're impacting, he said, if I just look at the biochemical structure of, let's say, this SSRI medication, or St. John's wort, or whatever the compound was that he was looking at, he's like, when I look at what it takes for the body to actually metabolize and break them down, I'm actually going to go with the pharmaceutical because it's sort of the purified version of what was helpful. So unless there's something synergistic about, the quote unquote natural compound in its entirety, it's not always better, and it's actually not even always safer to go down that route compared to, and again, I'm painting in very broad brushstrokes here with regard to these comparisons, but it is fascinating how the decision making process plays out, and kind of what we determine to be safe versus risky or likely to be effective or not worth our time, and how that all works. It's a fascinating endeavor.
I think one of the issues with clients or people, putting their dog on medication is there's that lead in where, you've got to wait a few weeks to see if it works. If it doesn't work, you've got to wean the dog off. You've got to trial another one. It's a long, slow process. And I think that also puts a lot of people off.
It does. And I think that's one of the places where working with a practitioner who's got a few tools in the toolbox can be really helpful. I know a lot of practitioners that I work with who are, I'm going to use the word dabbling in psychopharmaceuticals, and I don't mean that as a negative connotation, but who are just kind of branching into it, who may not have had the opportunity to have a significant education in that particular topic through their veterinary career, and so they're kind of treading lightly and trying out sort of one thing at a time. And having a conversation with a veterinary behaviorist, someone like myself or someone on my team, or all of the other veterinary behaviorists around the country, around the world, to be able to have that conversation, to say, hey, I'm in this situation that you just described there, Ness, to say, I've got an animal that has an urgent need tomorrow. I'm aware that if I go down the route of antidepressants, I'm going to be in that scenario you just described. Can I, even perhaps while I'm onboarding something along that pathway, can I also trial some situational meds to deal with the urgent concern? And truthfully, there are a few combinations that we tend to stay away from, but for the most part, the answer is an absolute yes. It's not necessarily an either or an or, but potentially a both and situation, as long as we're able to be aware of what the potential side effects are, what the interaction timeline is this a safe combination, and so on. And that's one of the things that I love being able to do. Either when I've got an animal who needs urgent help before a long-term med can be on board, or maybe we started with the long-term med and it's just not working. And so now it worked a little bit. So now I'm worried about regressing while I'm trying, even if I do a fast transition, there's still potentially a transition phase. So sometimes we'll layer in other supplements or medications to act as a bridge to try to reduce the potential for that regression during that transition time. But it comes down to kind of, again, knowing what's in your toolbox. What can you reach for safely? How do they work with one another? What are the indications for a particular patient, and where do you go forward? And that's a place where, as vet behaviorists, we can be an incredible resource to the veterinary community.
I have one last question. I mean, y'all might have other questions, but I have one last question, and it's kind of a can of worms. And it's my can of worms question that I saved till the end. No. Okay, so when working with vet behaviorists, frequently we run into the you should use food. And that is something that generally separation anxiety professionals don't use. And so can you talk to, I mean, is that something that you usually recommend? And if so, or even if not, can you talk to me about kind of, well, not really, let's just have a talk about it. I just want to have a discussion about it, because I wonder about this so much, because it's such a, it's like almost always a vet behaviorist will say, give them food, and almost always a separation anxiety specialist will say, no, don't give them food. So it's just something to talk about.
I love this conversation. Yes. And I'm sort of rewinding back to my initial point quite a few years ago now, where I was, kind of just starting to see some of these protocols coming through. And I was like, I don't know what's going on here. Really straight up desensitization without active counter conditioning? Like, I'm not sure that that's not sure. I'm not sure. So I was like the skeptic in the room as well. I'm like, well, and so here's the thing that I've well, I can go like 17 different directions here. I love cans of
Go
worms.
for it.
So some of the things that come to mind for me here, one is my clinical experience as a veterinary behaviorist has allowed me to mitigate the panic response through the use of medication, such that some of the arousal or the masking effect that is often there when using food for some patients. I'm gonna come back in circles. I realize I didn't define some of what I'm saying right now. I'll come back to it. That some of the negative effects that might be observed if an unmedicated patient is trying to sort of if an owner or a caregiver is kind of trying to keep the animal busy with food, or is trying to condition an emotional response with food, but the animal is over threshold, they're still eating, but they're over threshold. And we get into this weird conflict situation where the food itself may even be perpetuating the arousal and
Yes.
all of that, right?
Uh-huh.
That has not been a huge part of my learning history. Because
Okay.
most of the patients that I've been working with, we've not had the requirement or even necessarily, I mean, we try to minimize the number of departures and alone periods as much as possible. But again, with smart medication use, I can mitigate the panic to make that overall process more successful. So my learning history as a prescriber is that I'm able to reduce the emotional arousal through strategic use of meds. I'm able to avoid departures that are over threshold. And if I've done my job well, food usually leads to a positive conditioned emotional response, such that it doesn't feel like it's clouding the issue or creating that learning conflict for the individual animal. Now, if you take the medication away from that, I think, or even maybe aren't quite as judicious about how that's being applied, I absolutely hear all of the concerns where food can be problematic. I also find that, for my earlier training as well, in addition to the positive conditioned emotional response that we're talking about, I also do a lot of work with relaxation exercises and capturing relaxation, which I know all of you do in various degrees as well. So not saying that these are different things, but in those cases, utilizing a captured relaxation protocol that can be applied to the canine learner, even when they're in isolation and when the owner is not present, when it's done well, has allowed me to continue to exaggerate the relaxation response versus having an animal in quote unquote working mode for an entire 4-hour departure in expectation of food, which is what happens in my experience when it's done poorly or incorrectly. So again, back to the application. And this is a place where I actually personally I still do struggle, in that I see the value of, let's say, desensitization without the use of food, and work with a lot of patients who respond very, very well using a completely different toolbox. The trick for me, and this is where I'm really trying to get really super thoughtful in my own approach now, is trying to identify which learner I have in front of me before I then go down the pathway of saying, cool, yeah, I think you're absolutely on the right track. You're making progress. And here's how I may be able to work collaboratively with medication. Or I have a patient who is struggling to make that progress. And so could we try, even temporarily, could we try doing a different protocol to see whether or not that makes a difference for us? The difference, again, for me, I hope I'm able to express, is I'm not saying the way forward is to do it differently, but it's rather a saying, well, can we try this doing it differently? If the learner tells us that it's more successful using the same parameters that you're already using to monitor, cool. Then I think we just identified this particular learner as one where that protocol actually isn't the best option. But for me, it's not making the assumption that either protocol, and obviously I'm painting just like two protocol pictures here, that it's sort of an either or, when in fact there's a lot of ways to mix and match and mingle between the two. But I've got to be able to look and see how the learner in front of me responds to know whether or not I feel like I'm going down the right pathway.
Right.
Does that
Right.
help, or is it muddy waters even for my own person?
No, I think that's, I like that. I think one of the things that I really get hung up on is the order of operations, right? Like, so,
100%.
right, we're giving the food and then exposing them to the potentially scary thing. And so to me, then you're not really doing counter conditioning. You're doing more of like a distraction thing, or sometimes for some dogs, the frozen Kong becomes a pre-departure cue, and then they stop eating the Kong. But that's a whole other thing. But so I guess for me, I really get hung up on that piece of it.
As you should. Yes. No, it's a valid thing to be hung up on. Good for you. No, I completely agree with that. And it's one of the reasons why I tend to do a lot less of that. Again, there are some of my patients, mild, I don't even know that they would necessarily even get a separation anxiety diagnosis. They'd rather somebody were there with them. It's more of an express preference. Right? Why would social creatures, of course, that for some of those dogs, if I can keep them sort of busy and occupied through the departure and give them an oral engager for that initial 8 to 10 minutes, by the time they finish, they take a stretch, grab a drink of water, and they nap for 4 hours. For those patients, I have no objections, even though the order of operations is wrong. Happy as a clam, ready to go for it. The rest of them I have a problem with. Where we're getting exactly what you're describing is, especially if we have not actually made the departure that we are working with, if that is still in fact a scary thing, and we're predicting that with a long-lasting food item or a food scatter or whatever that happens to be. I completely agree with you on that. And it's one of the reasons why I tend to, for most of my patients, especially if that's already been their learning history, I really tend to do more of a captured relaxation protocol, which you're probably all very familiar with various versions of it. For anybody who's listening who may not be, we may start out in the room with the dog and simply capturing when they choose to offer a relaxed down, which sometimes we build a little reinforcement history in from the get-go, and then conditioning that. So the animal is getting reinforced for choosing that as an option. We're taking care throughout that process to not accidentally condition arousal into the working sequence. And when the dog is able to consistently choose that a number of times in a row, then we'll often move to the handler or the trainer, in that case, working either at a distance from the animal or perhaps across a baby gate, still in visual line of sight, but separated from, still really making this an active training process that's below threshold with the reinforcer coming after the behavior. And then we're able to usually at that point transition over to a remote activated food dispensing device of some sort, capturing the relaxation. And then as we move into the full departure sequence, continuing that generalization process for me, which puts the reinforcer, assuming it's meaningful, assuming we're actually getting a positive CER, which in my experience, we've been able to do, looking at them critically. But again, I'm also using meds. So I've got sort of that other piece of, all right, so I got different tools in the toolbox. When I do that, I actually find in my hands, that's a much faster way to work through the process than doing the desensitization without use of food. And again, I'm very broad brushstrokes here as well. And it's subjective, right? I've not done 342 cases each way to really, but my take has been when I recognize that as an inroad, I find that to be a more successful approach.
I think especially the relaxation protocol, I think can be especially helpful with those dogs who just have trouble relaxing, even when their pet parent is home. Like they just don't, either because of anxiety or just they've never learned how to do it, or whatever the reasons. Or I find it a lot with newly rescued dogs. They're still kind of settling in and having that relaxation protocol as part of the picture, even before we start moving towards the door or moving for separation or independence or whatever you want to call it. Just teaching that skill, I think can be a really important factor.
Yes. Yeah, I agree. I leverage a lot.
I think what I think I'm hearing from you, Dr. Pachel, is that you use a very selective and nuanced use of food and the relaxation protocol. And I think where we get stuck sometimes is when we come across a practitioner who uses food as a standard separation anxiety protocol without that selectiveness, or without that looking at, will this work for this particular dog or not? And I think that's where we have problems, isn't it, Stacey? Where and Ness, where there's just they're just kind of like, give them the food, and then you've got a dog, well, the dog doesn't eat the food, so what do you do then? Where do you go from there? Or like we've said, the dog eats the food and then goes, actually no, the food means you're going out, oh my god, I'm never eating ever again, and it all goes horribly wrong.
Or they finish the food and panic,
yeah, and then that's what worries us. Where do our clients go then when they've got someone who's telling them, no, you must use the food, and when it's all going horribly wrong? It's that kind of thing that we get concerned about, particularly when it's practitioners who, from where we are at a much higher level. I think that's where the sticking ground is, isn't it?
It gets, I love that. I love that point, Sarah. I mean, I think it's a really important distinction. And I remember when I first really started teasing out some of the nuance that you just pulled out of the conversation there, it really got me thinking about, the idea that for me as a practitioner, if I'm going to use food and it's in a very particular way for the right patient, if I'm going to avoid food, it's in a particular way for the right patient. And they become very different protocols based on the learning history, the learning style of the animal and their individual needs. And I hear 100% what you're saying about the poor application of the use of food in the separation anxiety treatment plan. And I truly can only imagine how incredibly frustrating that would be to run into that over and over and over, and like, oh God, come on.
And I think we wonder where it comes from. I think that's one of the things as well. Where does that particular practice come from? I mean, do you know? Do we know?
I could go back to all of my the archaic books from the 80s. And, it's in there, right? Right? It's like, okay, they're still here. They're still here. No, I think it's an overly simplified understanding of learning history and learning theory. The idea that I'm giving you something positive, of course it's going to make you feel better. Without actually asking the question, again, what's the order of operations? It's not making you feel better. It's actually predicting something that's quite the opposite, and just not being perhaps as up to speed to be able to have the conversation about the animal's learning history at that level. And for some of my colleagues who have historically recommended a much more liberal food protocol, when we actually piece it out, they're like, well, of course, that totally makes sense why that would be wrong. Oh my God, I've been doing that for the last 20 years. I've never actually given it another critical thought. I just learned that as the way we do that, and the conversation has not been had. So I think that's also something where, as learners, we also, well, let's go back to our path in the jungle or the forest, right? We go down that path of, being busy. I've got a protocol. It's worked, so I'm going to keep doing it without going, is it still the best option? Is it still the best way forward? If so, why? If not, why? And remaining curious about that. And I think that for probably all of us as humans, we have those blind spots in our own learning history and in our own recommendations even. So I would actually, this is a beautiful way to sort of wrap our conversation full circle, is coming back to that conversation with the practitioner. Hey, I've got some information about some protocols that, gosh, as we've learned some things over the last 5-8 years, it's kind of turning this whole treatment process on its head, I'd love to be able to walk you through why we're doing that, so that as we're working collaboratively, you and I get to be on the same page. And if you've got a reason why your protocol is different from mine, I'd love to hear it, and the opportunity to share that back and forth, so that we're not putting our shared clients in the middle of having to decide who to listen to, because that's really uncomfortable for everyone. Nobody needs that, especially our clients, So I bring it right back around to asking some questions and identifying those practitioners who are really looking for that same collaboration, who truly, truly, truly want the best for their patients as well, but maybe working with a toolbox that's a little rusty.
So Dr. P, I know you've got to leave in literally 2 minutes. So look at
I know, look, why did that time go? I just glanced down, I was like, oh yeah, I got a client that I'm meeting in about 2 minutes.
So
it's fine.
So thank you so much for joining us.
Yes, thank you.
Thank you.
Pleasure to have you on and talking about this, such a hard subject to talk about, but one that needs to be talked about. And yeah, it's just been amazing.
Thank you for having me on. I appreciate the conversation. And if there's any follow-ups that stem from this, if you get some questions coming in from folks who are hearing this and we need to do part 2, cool. Let me know. We'll get it on the calendar. I'm happy to do it. This is an amazing opportunity.
Fabulous.
Let's consider that a yes.
Yeah.
All right. Thank you so
awesome.
much.
Absolutely. Take care, everyone.
Thank you.
Bye.
Bye-bye.
Well, thank you very much for listening to this. What an amazing episode, ladies. I have just loved Dr. Pachel, and I can't believe we've been rabbiting on for 2 hours, but there you go.
I know, seriously.
I am Ness Jones. I'm from Separation Anxiety in Dogs Decoded in Australia.
And I am Stacey Bell from Focused Fun in the US. You can find me at focusedfun.net or Focused Fun Dogs on Instagram or Facebook.
And I'm Sarah McLaren from Separation Anxiety Solutions in the UK. You can find me on Facebook, Instagram, Pinterest, and my website is separationanxietysolutions.com. I just wanted to throw in a quick comment here to say that I will be going on a short hiatus until June because I'm moving on to a narrowboat. So you can look forward to sharing Ernie's separation anxiety journey once we move into his new environment. So there'll be probably some episodes about that, and you can share my journey with him. In the meantime, thank you so much for listening to us, and if you can share us, like us, give us a review, anything that will let other people know that we're here, and of course let Dr. Pachel know how wonderful he was, and to thank him for coming on. In the meantime, we'll see you next time. Bye.
Bye.